I'm Elisha Paul DeKoning, an emergency physician at Dartmouth-Hitchcock Medical Center and a contributor to Tintinelli's Access Emergency Medicine. The shoulder is by far the most frequently dislocated joint we encounter in the emergency department, and anterior dislocations are the most common. There are several techniques to reduce an anterior dislocation. The typical mechanism for acute anterior dislocation is one of extreme abduction, extension, and external rotation. Imagine this as preparing for a volleyball spike. It can also include a fall on an outstretched hand, particularly in the elderly. Patients with acute shoulder dislocations are usually in significant discomfort and limit any movement of the affected arm. However, chronic dislocators may have minimal pain. Patients usually hold their arm in slight abduction and external rotation. They resist abduction and internal rotation and are unable to touch the opposite shoulder. Indeed, if the patient is able to place the palm of their injured arm on the opposite shoulder, this suggests a dislocation. Aside from the clunk felt in most reductions, this maneuver can actually be used to confirm a successful reduction. The anterior dislocated shoulder looks squared off, and the deltoid contour is lost when compared to the other shoulder. You can palpate the humeral head anteriorly. Anterior dislocations are characterized by a subcoracoid position of the humeral head on the AP view. In the scapular Y view, the humeral head is positioned anterior to the Y. In the axillary view, the humeral head, or golf ball, has fallen anterior to the glenoid, or the T. A complete neurovascular exam is critical both pre- and post-reduction. Check the brachial or radial pulse, sensation over the area of the axillary nerve, and motor function of median, ulnar, and radial nerves. An absent pulse is an orthopedic emergency and requires immediate reduction. Obtain shoulder x-rays consisting of the AP, axillary, and scapular Y views to confirm the diagnosis and identify associated fractures. Patients with an atraumatic recurrent dislocation may be candidates for reduction without pre-reduction x-rays. Fracture dislocations of the humeral head or humeral shaft should be deferred to an orthopedist for reduction. Small avulsion fractures, Hill-Sachs lesions, which are impaction fractures of the posterolateral humeral head, or Bankart lesions, which are fractures of the anterior rim of the glenoid labrum, are not contraindications to reduction by an emergency physician, but these patients should have close orthopedic follow-up. These more minor fracture findings are quite common and are more indicative of a disposition to frequent dislocations than a consequence of the dislocation itself. After making the diagnosis of an anterior shoulder dislocation, obtain informed consent, gather needed medications, and, if necessary, equipment for procedural sedation. The indication for procedural sedation is multifactorial and depends upon the method you choose to reduce the dislocation, patient comorbidities and preference, as well as the need for urgent reduction. The details of procedural sedation will not be discussed here. In the patient that does not require procedural sedation, consider intra-articular injection of lidocaine to reduce patient discomfort and thus aid reduction. In some cases, this may be all the analgesia necessary. Multiple methods can be used to successfully reduce shoulder dislocations. All of the demonstrated techniques can be performed with either intravenous and/or intra-articular analgesia. You will likely have a favorite method, but familiarity with multiple techniques is helpful in difficult reductions. Successful reduction depends on time to reduction, patient comfort, and clinician experience. It must be emphasized, however, that clinician patience is vital to any successful reduction. The Stimson technique does not require an assistant and may be ideal for use in a busy department. Position the patient on an elevated stretcher in the prone position with the affected arm hanging over the side of the bed. Opioid analgesia, as well as low-dose muscle relaxants such as the lorazepam, both aid patient comfort and may assist reduction. Attach weights to the affected arm by use of a Velcro wrist splint or wrist strap in 5-pound increments. In a muscular developed patient, additional weight may be needed, but caution should be advised against too much weight, as this could cause vascular compromise or soft tissue trauma. With this gentle, slow traction, reduction often occurs within 15 to 20 minutes. In some cases, gentle external rotation can also assist reduction of the shoulder. The scapular manipulation method repositions the glenoid fossa itself. Push the inferior tip of the scapula medially towards the spine. Some dorsal displacement of the scapula is recommended. The multiple variations of this method make it popular and add to its success. However, it requires an assistant and some force, which may add to patient discomfort. Reductions take time. Rushing the procedure will likely add to patient discomfort, physician frustration, and the likelihood of a failed reduction. In the anterior dislocation of the left shoulder, place a looped bedsheet in the affected axilla. Next, place the patient in the supine position. A second bedsheet is placed in the affected antecubital fossa, holding the elbow at 90 degrees. Leaning backwards provides axial traction. The assistant provides counter traction. Gentle external rotation of the forearm reduces the humeral head from the glenoid. Classically, a palpable clunk signifies a successful reduction. Position the patient as close to the edge of the bed as possible. Apply counter traction in the same manner as before. Axial traction is applied with a looped bedsheet in the antecubital fossa and around the operator's foot like a gas pedal. Gently press downward with your foot while simultaneously externally rotating the arm. This reduces the humeral head from the glenoid. After reduction, place the patient in a simple shoulder sling. A post-reduction neuroexam should be documented on all patients. Confirm reduction with post-procedure radiographs. This also serves to identify any previously unseen fractures. Close orthopedic follow-up is indicated in patients with evidence of a brachial plexus injury. However, isolated paresthesias in the axillary nerve distribution are typically self-limited. Patients should remain in the sling until orthopedic follow-up, typically within 5 to 7 days. NSAIDs may be used for outpatient pain management. Opioid analgesics will likely be needed for breakthrough pain.